Hi, everyone. Hi, Peter. I see you. I noticed you just chatted. Um, so I'm Mike Seidman. I currently work in Toronto, Ontario. I am American, at least. Well, I am American, and I'm also going to be Canadian in tomorrow afternoon. I was asked to do Journal Club today. Doing it on an article that I was the reviewer for, that I wrote the editorial for, and on which there is a topically related review in CV Path that I was a co-author on relatively recently. So I felt qualified to talk about it, but that is also admittedly a conflict of interest. So anything where you disagree with me, I encourage you to blame Rick Mitchell. Rick Mitchell got me involved with SCVP roughly 15 years ago, and it's all his fault. Is Rick on? That would be awesome. No, that takes all the fun out of it.
No, but I'm
Um,
gonna tell them, don't worry.
no, okay, thanks. Um, Also, I don't immediately recognize any names from the manuscript, but since like SCVP has like become a big deal and like international recognition and all, is anyone from is any of the authors from the paper on so that I can like collaborate with you and correct stuff? And no, nobody. I don't know. I always magically hope that the authors show up, but hasn't happened yet. Um, so I'm going to be talking about this manuscript. It was importantly in the Canadian Journal of Cardiology, which one, despite being called Canadian Journal of Cardiology, within strictly cardiology, Elsevier tracks it as the fifth highest impact factor in their portfolio. What was admittedly a regional journal at some point has grown tremendously. Impact factor is somewhere around 5.2 this year. I don't want to make it like I'm doing this little esoteric nothing. I am on the editorial board. I am, to the best of my knowledge, currently the only pathologist left on the editorial board, which forces the editor to send me lots of papers. So if you'd like to read stuff where you can tell cardiologists how bad they are at pathology, please let me know. Stan Nutella, the editor, is a wonderful human being, and I'm sure he'd love to have backups when I say no. And so the other thing about this is that it is a cardiology journal. So this manuscript is targeted to a cardiology audience, and I reviewed it in that context, which means I was a little more forgiving about some of the pathology stuff because I really wanted it published. I thought it was really important that this message get out. So when you get to the point where it's like, well, why didn't the reviewer catch that? Because I was being really nice, to be perfectly honest. The other reviewer, ironically, for once, I wasn't reviewer two. Normally, I'm the stereotypical reviewer two. I was the person advocating for publishing this one. So I was a little more relaxed than I am sometimes. Is Joe on? No, no, no. I don't see him. So if Joe were on, I would specifically point out that this is how lazy I am now from now on, and I shouldn't be invited to review. Okay, moving on. Mandatory disclosures, as I said, I'm pretty heavily involved in all of these, so I probably have conflicts of interest that are implicit and I don't even notice. Please forgive me for those. I'm pretty sure I have everything else covered. What very little content in here is mine. Please feel free to reuse. Just say, hey, Seidman said. So this is from the review published last year in Cardiovascular Pathology. Greg Fishbein spearheaded this group as a result of a series of talks we did in the specialty meeting in, it's not called that, Companion Society meeting at USCAP. And Greg got us to all put some stuff together about this. And due to no fault of my own, makes a really compelling case for using EM, talks about some really good uses of it. I got to wax philosophical at the end, but there was nothing factual in it. So there's lots of cool indications for EM still. I encourage you to at least know where to send specimens when they need it. Although the classic teaching is that you can't do it on stuff submitted in formalin or processed to FFPE, believe it or not, you can. It is easier to do from the wax than it is from the formalin. You can deparaffinize it. All of the images I submitted to this manuscript, which includes the one on the top left, are deparaffinized, and that one's probably one of the worst images I've ever acquired at my institution. We normally do get stuff for EM, but more often than not, the really complicated cases, I identify after the fact. And that speaks to some of the secondary messaging in the manuscript that I'm focusing on today, in that we probably have all seen a case by this point where it's like, I really wish they had sent for EM because blah, 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 blah. It's at least worth trying doing it from paraffin. If your lab does not have experience with it, our lab can happily send you the technique. Believe it or not, the group in Kuala Lumpur successfully validated it off their written documents. So clearly, Lee, our EM tech, is really good at writing documents. And clearly, I didn't write it. So anyway, this is some of the fun stuff we know to look for. Today, we're going to be focusing on amyloid, which I was always taught, again, you can blame Rick for this, that amyloid being a diffuse disease, the biopsy should be insanely sensitive for it. It shouldn't be a problem. Why would you ever need the EM, blah, 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 blah. I will say definitively, I don't believe that anymore. And I'll speak a little bit about that on the next slide. The fibers have a very distinctive size. They're normally even less organized than seen in this picture. This is just the one we ended up using for publication because I think it was in focus. It is definitely more sensitive on average than bright field. That said, I only ever run the EM if the bright field is negative or indeterminate. So I will be intrinsically biased thinking it's more sensitive, and didn't structure a study nearly as well done as the one I'm going to be talking about. They actually have a very good design that just honestly they could have described a little bit better. From a pathology point of view, it was really well described from a cardiologist point of view. Very few groups are currently able to type amyloid on EM. You, in theory, can do it by both immunostaining and by spectroscopy methods. The immunostaining method, I have heard a couple groups that tried it now said is actually less reliable than the IF, and I don't believe the IF half the time. So there's obviously some work to be done there. I think part of it's because we're using immunogold. I think nanosphere immunostaining in EM will go a long way, especially when you then start using computer-assisted algorithms, AI, and all that fancy stuff to superimpose on structures. And it's like you have to have this, this, and this all true kind of stuff. EM spectroscopy, I actually haven't encountered a clinical lab using yet, but I'm really keen to try it because in theory, you know, just like tissue mass spec, you're going to get all sorts of cool information out of that that's sort of right on the horizon, but not in clinical use yet, probably because pathologists are terrified of having that much information in front of them. One of the tricky things, and one of the things that I think is relevant when talking about the manuscript we're going to talk about, by the way, I should say, interrupt me when you have anything to interrupt. Since not everyone here is quite as familiar with me, I tend to just keep talking. I don't think I've ever stopped talking unless someone interrupted me. They had to give me a talking stick in Vancouver. So by all means, if you have thoughts, questions, feedback, etc., just jump in. So we only tend to submit one little piece for EM, which should be more than sufficient for a diffuse disease, but in light of what we're going to be discussing today, does raise some interesting questions. And I'm convinced that new imaging, lab tests, et cetera, and even just clinicians saying, maybe it's amyloid, we are seeing biopsies earlier in the disease course than we used to. You know, when I was in training, they were pretty sure it was amyloid by the time it got to us. I feel like 50% of the cases that come to me now in my practice, they're genuinely not sure. And I think that one improves the magnitude of the role we play. Like we're more than just confirmatory, we're impactful. Obviously, we're the ones that facilitate typing it, regardless of the method you might use. But it then also requires us to shift our focus from, no, it's not 98+% sensitive. It's not perfectly specific, et cetera, et cetera. So again, this is in a cardiology journal. Just keep that in mind. So a lot of the way it's written will not read like a pathology paper. I know you all read this at least 2 or 3 times, took extensive notes. I encourage you to share those with the group in the chat. So highlighting some of the methods. I really like that they specifically only included cases in this study where they got 3 or more pieces, and that always one of them was submitted for EM, and that whatever additional number they got went to FFPE. The average was about 2.6, if I remember correctly, and didn't vary across their specimen collection enough to matter in their results. So actually, I thought that was really great. I actually asked them to add this detail because I think it informs both the pathology interpretation and encourages the clinicians to understand I only want 1 free EM. Don't send me like 12 because I want those all in FFPE because that tells me a different set of stuff. It was interesting that, sorry, go ahead, David.
Well, One question, well, that I have is I didn't understand how the patients were actually selected. So, in other words, did these patients, were they all people who had first an echo or something like that, and that was the suggestion? Or were these just diagnostic biopsies as a whole? It was kind of confusing to me in terms of how they selected the actual. I would have liked to have seen a flow diagram to sort of say, here's all the patients, here's a subset with, I don't know,
Yeah.
left ventricular enlargement or something like that. And then here's a subset we saw, something like that.
And I actually asked them that in the first revision. They said that it was everything where it came in with a question of amyloid question mark. And since
Okay.
so many of them were coming in as referrals, that they didn't feel that figure would add anything. We're all used to the New England Journal figure 1, and it's very satisfying, it's very reassuring, and it is buried in their methods that there was no uniformity when it came to them. Most of them got the high quality echo after showing up for biopsy. In some ways, this is reflective of many of our referral centers, right? Most of my biopsies come from a person who's involved in the tafamidis trials, et cetera, et cetera. A lot of them come from centers where they don't really understand different types of amyloid. So I actually found this very representative in that regard, especially from a clinician point of view, that it doesn't matter what triggers it. They said like one of them literally got sent because they met New York Heart Association criteria, so they had shortness of breath and had myeloma and were sent for workup and ended up being positive if I do the correlation between their comments correctly. So it's a really great question. I I think I did try at some point to piece them together across the different tables, and it ended up being irrelevant. That it didn't actually change my interpretation, but it is an interesting question. Because I would argue most of us these days are seeing someone who has an abnormal lab value or abnormal imaging. Most of ours actually have an abnormal CT or technetium scan these days. But I also work at an overfunded center, which is ironic. Pathology is underfunded, but we have lots of money. I was surprised that they only use 3 micron sections. I've never gotten 3 micron sections to work reliably for Congo Red. All the manufacturers recommend at least 6, if not 8. I revalidated all of ours at 8. They work much better now. But they say it worked, so I don't feel that concerned about it. The rates that it worked at are as high as I see on 8 microns. So kind of I want to get their slides. But anyway, I just think that was an interesting observation. They define positive as either Congo Red positive or EM positive, and the FFP was strictly defined by Congo Red. I have to admit I've had a lot of cases where it was positive on everything but the Congo Red. I also use sulfated Alcian blue religiously because it is so much more sensitive. So there are some interesting questions embedded in that, but it's important to note in the methods interpreting it. And there is a known artifact that, depending on how you do your Congo Red, you may or may have not have seen, particularly under polarization, a significant fraction of the time myocardium is false positive. And you can actually see it stains the myofibrils. And it's a really cool picture, but if you don't know what you're looking at as an artifact, you're going to overcall the case. Now, what they didn't comment on was the fact that fibrin is also frequently false positive. So, that's one of the things to consider interpreting this, especially with a relatively small sample size. But they clearly put a lot of thought into getting a high quality sample that wasn't random per se, but designed to answer the question at hand. So I actually was fairly impressed. And most of this was in the first draft. They did a really solid job of this. The thing that blew my mind is they do 10 grids or more on every case. I cannot imagine doing that in our center. In general, I might get 10 at most where I look at the toluidine blues, but I only ever run 1 or 2 grids. The expense of that is obviously non-trivial. So, it does beg some interesting questions as to the cost effectiveness of this. That said, I do cut everything to a toluidine blue because at least I can say I histologically saw it then. Believe it or not, I do that with all of our diagnostic cases, and I caught myocarditis on it once. As I said, either modality was enough to be positive. They didn't use mass spec for their typing. I don't think the typing data necessarily impacts anything in their findings, but just to keep in mind, oh, wait, they didn't use mass spec, they used immunostaining. How does that translate to the downstream impact, et cetera, et cetera, et cetera? They did mention that they tried immunogold in one case and it didn't work. And as I said, most places haven't gotten it to work robustly, which again, immunogold's messy. That doesn't usually surprise me. The results were actually really cool. 65 of the 72 cases referred to them in any way of, is this amyloid, were positive for amyloid, which actually shows that their clinical pretest probability was actually shockingly high. Most of those, as you would expect, are ATTR. Some of them were AL, and one of them, unclassified, meant that they couldn't type it by IF. I have a sneaking suspicion that mass spec would have identified it. We also know, obviously, that some fraction of the ones done by IF, mass spec would disagree. We can go into a whole separate discussion, ideally when Joe's here to defend himself, as to what gold standard should be, et cetera, et cetera. Interestingly, they did point out that the bright field Congo red staining, the salmon pink, and the polarization were 100% concordant, which I think is insanely cool. Speaks to the quality of their stain, the quality of their polarization. But I actually find polarization more sensitive. It is admittedly less specific, harder to interpret when it's not pink, et cetera. But I'm kind of curious, were they using LED? Was it high intensity? What kind of condenser were they using? And was it digitally enhanced? None of which, in my opinion, impacted the findings, so I didn't bother asking them to put it in there. Of the 65 cases that were positive, 60 of them were positive by most modalities. Very reassuring. When we call it positive, it's positive. We can move on. And then I'll get into the discordant ones in a second, but whether it was AL or ATTR did not seem to impact whether or not it was positive on one modality versus both, which I can't say I'm surprised, but it's very reassuring. They didn't comment on the pattern, so the interstitial, nodular, multifocal, diffuse, et cetera, et cetera. But again, I'm not sure it impacts their findings. It just would be interesting. This would be a good example of, I'd love for these digital slides to be in a public data set sometime and be able to use for secondary and tertiary analyses. I don't think the world's quite there yet, but I can hope. So the figures were all case examples, and they put in only 2 of these, I think, originally. I'm like, guys, if you still have the slides on any of them, why don't you put them all in? It'll be really interesting for people to see. So all of the discordant cases except one, I think they still had the slides for. So this is a nice example of a concordant case. When it's that positive on H&E, I have to admit I'd be really worried if it were discordant, because that means someone did something wrong. Really nice example. We've all seen these cases before where, of course, we know what it is, staining correctly, blah, 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 blah. Of note, they only took pictures of the bright field Congo red. It is admittedly harder to take pictures of polarized light, especially if you're using digital slides. There is no scanner that does it correctly yet. So they are showing the salmon pink. I upped brightness and contrast a little in presenting these just to emphasize that, in fact, there are pink areas there, and they correspond to the paleoeosinophilic amorphous glassy areas on the H&E. Their IHC staining was dirty, but yet I couldn't convince myself any of it was false. So they showed them for both ATTR and AL cases, and it was reasonably believable. So that didn't bother me, and again, the type I don't think influenced it. Sorry, IHC, and then the, sorry, I'm all confused here. G is the polarization, I think, on this one. Now I'm actually not sure, because what I wrote in my 2 different sets of notes here disagrees. Give me 1 second, because this is actually a relevant point. If the IF and the IHC don't agree. Does anyone remember? Where's the paper? Oh, wait. Chat? No, not chat. Sorry, folks. 1 second. I think this would be worth looking at. Nope, not that one. Disappeared. That's really strange.
Michael, on my copy of the PDF,
Yes.
there's very faint green color in
Yeah,
spots.
but how is it labeled? Panel G is labeled as IF or polarization?
G, hold on, let me go back. It is labeled, G is labeled polarized light
Okay.
microscope.
Okay, so I should have stuck with my original set of notes, not the set of notes I'm reading from right now. So they did take picture of the polarized light. I would
Yeah,
actually argue that's not concordant with the salmon pink. It doesn't match. This actually has a slightly different pattern in my eye.
I
None,
agree.
yeah. As you point out in the PDF, it's really hard to see. The digital image downloaded is actually much better. I was disappointed with the print quality, but that's the printer, not them. So there was nothing I could do about that. But nonetheless, this was an example of a concordant case, so I can't say that I got too worked up about it. This was an example of the two cases that were only identified on EM. Nothing bothers me about this. I have had cases like this that were completely negative. I had one that had 7 pieces on the FFPE, completely negative by trichrome, MOVAT, SAB, Congo red, polarized using digital enhancement, you name it, it was negative and was positive on the EM. Which, when it's 1 piece versus 7 pieces, I have trouble believing that sampling. I think legitimately there is a pattern of EM or patterns that we are not picking up on the stains on FFPE. Now, many of my cases are focal. The one in the case I'm talking about, literally every single field of view on EM had amyloid in it, and it was dead negative on the FFP workup. We literally went and confirmed identity. It was so bizarre. Yes, Mark.
So on that case where you saw EM everywhere and you went back and looked carefully then at all your slides, you really couldn't see anything.
Nothing. I repeated the SAB. I repeated the Congo red because I was having such trouble believing it.
So
So
I guess I have a follow-up question. I mean, we're assuming that the EM morphology is pathognomonic of amyloid.
exactly. Oh, you
You
preempted
know,
one of my
are
questions.
there any other
Yeah.
entities? I remember one of my renal pathology colleagues saying that there's occasional stuff that looks like that, that really isn't amyloid. I'm just wondering if anyone else has any experience along those lines.
So, funny story. Uh, we see a high rate of fibrils that are 12 to 16 nanometers, which is inconsistent with amyloid, but looks just like this. Now, I have 2 working hypotheses. One, there's a fibril that we don't know what it is, and I've asked a lot of people. I've even searched for any description in the literature of a fibril 12 to 16 nanometers in size. There is literally nothing that is that size that should be extracellular, and there is no cytoskeletal protein that precipitates in that pattern. So I actually think it's an artifact. I suspect most of those cases were cases where we went from FFPE to EM, and it's artificially enlarged on the measurement. That said, I also couldn't find anything that looked like amyloid in the process. So the combination of the size and the haphazard arrangement appears, as far as the current world is aware, to be specific. There's nothing that's 100% specific. I reject that in every way, shape, and form. But I have heard from other people before that supposedly it's not specific. When measured carefully, I have yet to figure out anything else that it can be, and our renal pathologists agree with me. Anyone else want to weigh in? Does anyone else know something else that could mimic this? Especially when it's diffuse. When it's focal, I'm very hesitant to believe anything, right? Like if I only have one tiny little focus of something, that could be gremlins. But when it's diffuse like this picture, like they're showing, I mean, the low power field that they showed, the fact that they couldn't find it on FFPE blows my mind. And yet I had a case like this. So, and I had it before I reviewed the manuscript. So I'm like, oh yeah, that's totally a thing. Does anyone else have experience they want to share? Everyone's like, we don't know what you're talking about. What? Huh?
So, Michael, our experience and at least my approach and my colleagues in Houston is if we rely on EM a lot when the light microscopy seems to be equivocal.
Yeah.
And the EM can
Slam
be
dunk. Yeah.
helpful in confirming the diagnosis.
So that's what we were doing here when I got here. Jagdish used to run all of them. He had scaled back to doing only the equivocal cases, which I'm pretty sure was budget driven. But then we had several cases where the clinicians are like, every lab indicator, every imaging indicator on multiple modalities are positive. And I'm like, okay, I'll do the EM. The first 3 I did were positive. Now I've had double negatives. Like I want to say this is not, it wasn't just everything's positive. So we now run every negative FFPE case by EM, and 20% come back positive, give or take. So we upped our sensitivity. But yeah, there's a lot unknown here. And I think that's the coolest takeaway from this, is we've all been operating under assumptions that were told to us by very brilliant people over many years of data. We forgot to correct for the fact that the clinical world evolved. And I think there's just a lot of new out there. Plus, I love opportunities to do things cool and expensive. That's the Harvard in me, sorry. Is anyone, Barbara, I guess you're the person most likely to be able to defend that statement. Anyway, she's like smirking at how stupid I am.
Ha 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 ha.
Thank you.
Mike. Hey,
Yeah.
Charles. Hey,
Hey.
I got to be upfront that I didn't read the paper, but great job presenting it.
Thank you.
I guess the question here is, oh yeah, obviously it's shocking, right, to know that you wonder how many cases you've missed. I guess the one argument would be like, where's the control group? As in, like, let's take the cases that were not sent in for amyloid, do EM on them, and then are we, like, what's the clinical significance of, certainly if there's a suspicion of amyloid and it's sent in and you find it, well, that's probably the reason why there's cardiac dysfunction or whatever they're looking for. But, is amyloid that you can see on H&E different than amyloid that you can't see in clinically speaking? And you'd kind of need a control group of biopsies that were not indicated for amyloid. Do EM, right. How many you find amyloid in them on EM? And I guess they didn't do that here, or I don't know in your experience if you've come across studies like that.
So I do have experience, which I'll speak to in a second. They said that they didn't have the data and weren't in a position to go back and stain them because they didn't receive them with material for EM if it wasn't suspicious. Their protocol at that institution just didn't play out. We frequently do receive the material, and if it's not myocarditis, we often, I'd say probably half the time, end up running the EM because we want to know if we're missing subtle storage disease. Oh, cool. How did I miss that? What journal were you in, Max?
Getting there. Frontiers in Cardiovascular Medicine.
Okay, so I actually know I'm behind on my table of contents of that, so that's really cool. And I'm assuming that it said it was almost never, but probably not never. Am I right?
Basic idea here is that we divided the biopsies. We did all of the subclassification, but clinically, if the biopsy showed less than 5% or more than 5% amyloid, the greater than 5% ones correlated with some of their echocardiographic parameters. But the number of cases was too small to have major import on predicting mortality just from the biopsy.
Cool. So I ended up, and this was also triggered by that case where the FFP really should have been positive. I've reviewed, I think it was 18-ish, all non-controlled. None of this is publishable because it was done, my methods were, off the side of my desk. But none of the biopsies that were sent in not for amyloid showed amyloid. We have had one heart that came in that was HCM, confirmed HCM, genetically confirmed, had disarray on EM, and yet when running the EM, which I can't even remember why we did, also showed focal amyloid. So to your point, Charles, on biopsy, I don't know what I would do with it if it was on a specimen where it wasn't indicated. Obviously, I'd report it. On explants, I would be extraordinarily hesitant to do anything with it because, just the biology of it is the protein's going to precipitate in everyone. It starts somewhere. And that certainly doesn't make it clinically significant.
Right.
I can't imagine how many biopsies you'd need to look at to be certain, right? Obviously, if you find a positive on a not suspicious case, that's meaningful. Means we're oversensitive, so to speak. My suspicion is it's going to be a rare event. And then again, you end up with the, well, what if it's just not clinically significant yet? So many people get senile TTR, for example.
Yeah, well, exactly. Like in the appendectomy,
Yeah.
specimens you find a little bit and didn't really have an impact. Are the cases we identify via EM only with no morphologic changes? How can we hang our hat on that and then go ahead and treat and make that's for sure responsible for the clinical picture? I guess that's.
And in most funding environments that I'm familiar with, Europe and North America, positive biopsy, even absent everything else, is sufficient to get funding for tafamidis.
Yeah, that's a whole other question.
So it's like, oh wait,
funding.
are we now justifying inappropriate treatment?
Right.
So it's a great question. Maybe this is something where SCVP has an opportunity. Maybe we should start a registry of this. Maybe we can't have the capacity to put the whole slide images up. That's server intensive. But reference from Max. So everyone take a pause, read that from Max, and then
There should be only one T in Kotrupitskas.
it's all good.
Anyway, thanks for that little sidebar.
Yeah, so this is one of the reasons I really enjoyed this paper. It's just how many questions immediately came out of it. And I'm like, these are better questions for the public to have a chance to think about, which is why one of the many reasons I was less nitpicky about the paper. It was well written. It was clear. Everything was evident to me. These were one of the two cases where it was Congo red positive and EM negative. It's nice that they present like, hey, there were mimics, but we were sure they weren't amyloid. Here, at least, the birefringence matches the H&E and matches the Congo red to my eye. It's much more convincing. Everything fits together. The EM being negative doesn't bother me nearly as much because, in theory, the 10 grades were generated from one single piece of tissue. We know that EM can be not diffuse. So it was just interesting that it spoke to the, well, wait, you still can't do EM only even when you get your spectroscopy up and running, which I don't think anyone would have done anyway. There's a different set of tools available, and we all enjoy running the mass spec now, and yada, yada, yada. So I thought this was very nice that they did have a couple of these and sort of validated you're sending only one piece because no one's going to process 50 grids. But at the same time, all of the limitations of you're sending one piece are there. Now, I have to admit, the craziest thing was when I reread, actually post-publication, all the things associated with single method positivity versus double method positivity. So if they were only detected with a single method, they had a higher prevalence of AFib regardless of the type of amyloid it was. It was like 3 and 2. So it wasn't any of that. The indeterminate case was detected on both, so it's not like that was A and P or anything like that. So I found that absolutely fascinating, and then raising interesting questions related to that, because the relationship between amyloid and AFib is so complicated anyway. A lot of the measurements were like subtler disease. That jives with me. The lower EF fascinates me and almost makes me wonder if, well, all you had to hang your hat on was restrictive heart disease. So, you'll also notice apical sparing was a little bit different. It was more dilated. I'll come back to the PYP. But, this almost made me wonder, okay, so are some of the single positives overly sensitive? Like, is it restrictive heart disease, but it might not actually have been amyloid regardless of which single method was positive? And I think all of us can take for granted if both methods are positive, we're more sure than if only one method is positive. And especially depending on if radiology is also positive and echo is also positive, blah, 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 blah. And then when it got to the lower positivity rate, at first thought that made sense to me. But then I'm like, well, wait, if my hypothesis is that we're picking them up because we're doing crazy things like the technetium scanning, then that proves me wrong. So there is some increased clinical sensitivity implied that has nothing to do with the fancy new imaging modalities. So the only thing I could come up with, and I did mention this way back at the beginning, is an increased awareness of, hey, if the patient has X, Y, and Z, maybe you should ask this. I don't know if anyone has any of it. We do, in fact, run mass spec. We, in fact, do it in-house. I don't know why it was felt necessary to do it in-house. It's actually no less expensive than sending it to Mayo, but we do it in-house the same, and we get really good results. We validated it sending it to Mayo originally. I think they did 100 cases, and so I can get it run in-house. We're the referral center for at least all of Ontario. BC is ironically still sending to Mayo, but that was my decision, so make of that what you will. Yeah, so we do have access to it. We run it religiously. Jagdish didn't believe in the IF or IHC. I trained in an environment that didn't believe in it. So, you know, Jim Stone made a really good point to me many years ago. It's context specific. Depending on your patient population, your pretest probability is going to change for the different stains, how many controls you run. So we were running a panel at Brigham that I think was 9 stains. It was the same as the renal amyloid IHC panel, and I still didn't believe it. So I really like having the mass spec available. I will also say the fluorescence is definitely more sensitive. So I've had a bunch of cases that were equivocal by all the traditional methods. I dropped the Congo Red under the fluorescent scope, and it's slam dunk positive or negative. So for those unaware, Congo Red is fluorescent in the TTR channel, in the Texas Red channel. It's actually broad. You actually need a broad pass. So it excites somewhere around light green, dark green, light blue. So it's a cyan excitation and a dark red emission. But you can approximate it with the Texas Red filter. So anyway, I actually thought this was one of the coolest things because it forced some really interesting questions. So then in his infinite wisdom, the editor asked me to write an editorial, and I used this to get on a soapbox to remind cardiologists still do the biopsy. As much as our institution doesn't think this, but I have encountered plenty of institutions where it's like, well, we have the pyrophosphate, we don't need it anymore, or we have the technetium and blah, 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 blah. And I would argue that this manuscript proves that we still have an important role. Even if they don't care about amyloid typing, there's already plenty of literature to show that they're going to get the type wrong often enough that they should be sending it. I also used it to put in a plug for sending enough tissue. Literally the day I was submitting this, I got a biopsy for amyloid with 1 piece of tissue in the whole biopsy. So I'm like, yeah, maybe I should toss this sentence in. So I ended with the please send us enough tissue. That's the slides I prepared, which aren't you proud of me? I prepared in advance of Journal Club. Some people have spoken up. How about the people who haven't spoken up? There's people from all over the world here. This is so cool.
Fluorescence of other stains other than Congo Red.
Sorry, say again.
I can't remember the stain, but our former renal pathologist used to use something else.
We use SAB. Thioflavin. Thioflavin T.
Thioflavin, yes, that's right.
Is, in my experience, exactly the same as Congo Red fluorescence. So we stopped doing it here, actually. We use Congo Red for our microdissection. We stopped doing thioflavin because it was more expensive, ironically. Mark's up. Mark raises his hand. He's so polite.
Flavin asked at the Cleveland Clinic, and it's very good if you have a fluorescence scope. Actually, I just had a case the other day where the clinicians wanted me to get a Congo Red for a clinical trial. The patient was required as part of the trial, even though we had already called the case and signed it out with the thioflavin S. And going back to the Congo Red, which I look at under polarization, by fluorescence, not polarization, I was actually surprised by how much more amyloid the thioflavin picked up than the Congo Red. So
fluorescence, you said
that they thought they were equivalent. It's been our experience with thioflavin that we see more amyloid than on a Congo Red. So whatever, to each their own, but we feel pretty good about that.
And you said you use S, not T?
Yeah, that's the one we have here, S, not T.
So I wonder if that's the difference, because we only ever had T here. There are people who swear by one or the other. I have never figured out why. But yeah, so thanks, Mark. That's really interesting. We still have the reagents, so maybe we'll try it again.
Yeah, the renal pathologists use thioflavin T where we are too, and I've had a couple of cases I've asked them to look at, and it does seem to be better than Congo Red.
Congo Red bright field, though, you're saying?
Yeah.
Yeah, my Congo Red fluorescence is about 10 times better than my Congo Red FFP.
Never, yeah.
Or,
so
sorry.
I've done it. So you do the stain as you would, let's say your protocol's 8 microns. You do the regular staining, and then but just read it under the fluorescence scope.
Yep, has a very high background. I will warn you. So make sure you have something resembling a control or train yourself. But positive is obnoxiously bright orange.
Huh.
I will also say, for those of you that rely only on your eyes, no matter how good your scope is, digital scope cameras auto adjust their gamma, so it is actually much better at picking it up as well. So something where you're like, I'm not sure, put it on your camera and view it in real time, and it's just amazing how much better it is. Thoughts, comments?
Since I've done this, but my attempts to type amyloid with immunohistochemistry was total disaster. Just brown stain with everything all over the place, and I gave that up a long time ago.
Yeah. Yeah, I don't know that I've ever been anywhere where I've seen the IHC in-house, so I can't speak to that. The IF isn't any better, in my opinion. I mean, the bottom line is extracellular proteins are not great for staining by immunostain. They're really finicky because intrinsically they just have different chemistries. Plus, mass spec's cool.
I have a question about maybe a slightly different context. So at our institution, probably at yours as well, I don't know, the surgeons will frequently, if they're doing, open chest surgery, will remove the left atrial appendage. My sense is that, oftentimes it's because there's a history of atrial fibrillation, but not necessarily. And occasionally, we screen them H&E wise, but if I see something on H&E that looks like amyloid, we will, determine whether do the Congo Red at least to do that. Any sense as to kind of what the protocol is? Because some cases I've wondered, either I don't see it or I see so little of it that I begin to wonder, okay, are we just, adding tests to this case, or the clinicians? I mean, typically we put it in the report and we'll let the clinicians basically just tell us whether or not they want us to send it for subtyping. But I mean, do you send all of your positive anything for that's myocardium for subtyping?
Yeah, and the specific reason why is the overwhelming majority of the appendages are AANP, which it's not that it never involves the ventricles, it's just almost never. So they just follow the patient. And then there's really cool data. AANP is actually more likely in the context of mitral regurg, which is more likely in the context of AFib. AFib also causes aberrant signaling, and then that actually creates a loop. So there's some evidence that a subset of congenital AFib is actually ANP mutations, where the amyloid is the problem, which is so cool. I actually found that with Cricket Seidman by accident. I thought that was insanely cool. I don't know if she ever published it, though. But so we run all of them when that happens. I have had one that was TTR. Joe encouraged me to really, there was a case that by all rights should have been AANP, but was TTR. So that patient actually underwent additional scanning, had nothing, and is now just being monitored. So you could argue that didn't accomplish anything. But we do run them. But part of that's because it's in-house, it's easy to get done, et cetera. I also never had a focal. For me, it's like it's positive or negative. They've been real easy. But I have the same problem. I've had 2 isolated giant cell myocarditis of the atrial appendage, which is also described, and in none of them was there anything else. That said, I've also had isolated giant cell myocarditis in an HCM septal myectomy that had nothing else, had never had alcohol, blah, 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 blah. So I think there's just a lot of these things where, going back to Charles's point, we're insanely sensitive for stuff that might not be clinically relevant. And I try to think through the, am I going to do it? For the atrial appendages, I am running all of them where I identify it. The flip side of that being, I don't take micro on my atrial appendages if they're normal anymore. So unless there's a compelling reason, I do gross only, which has also eliminated that problem. By the way, in Canada, we're a little bit more resource sensitive than the US, and I don't mean that as a judgment. I'm actually saying, like, I can't spend as much money anymore. So switching to gross only was sort of a resource utilization stewardship argument. Charles can appreciate.
Yeah, well, I don't know, I maybe contradict your point. We send them all also. If we find amyloid, we send it. Just because, as you said, you might find the one case that's TTR, or I mean, I don't think I've had one with AL or whatever, but you never know. And then
right.
That puts that patient on the radar. Whereas if we don't, they maybe just assume it's natriuretic peptide. So
yeah, the interesting thing being the one that was positive here for ATTR, I identified grossly. You could see the waxy deposits, it didn't deform correctly, etc. So it was actually the PA grossed it, described it, sent me the picture of it, because if it's gross only, obviously I want to see it. Looked at it, I'm like, oh no, submit that. And it turned out to be ATTR. So, this is one of the reasons I go to gross only on a lot of specimens, is the ones that matter histologically, you tend to be able to tell they're abnormal. I actually stand by you can do the same with diverticulitis, but that's a whole separate conversation. I also want our septomyectomies to go gross only. And you can never tell Jagdish we do our valves gross only. Jagdish probably just logged on. No, okay. Well, I'm certainly not going to force people to stick around. I know a lot of you are experiencing nice tropical weather, which would be not nearly as funny if there's anyone from LA here, and I apologize. But I saw that smirk. I really appreciate everyone showing up. I think this is a really cool topic because, it's something we all trained as taking for granted, and now it's reopened, right? It's something evolving. And if nothing else, speaks to the read your tables of contents and maybe talk to your clinicians every so often. I know it's painful, but.
Thank you.
yeah.
Thank you, everyone. This has been fun. Thanks, Peter. Tiana, thanks so much for hosting.
Thank you.
Take care, everyone.